Our speakers today, you can see on camera, are Dr. Francesco Branca, Director of the World Health Organization Department of Nutrition and Food Safety. He will give an overview of the issues. Then he will hand to Dr. Mary Schubauer-Berrigan, who's the acting head of the International Agency for Research on Cancer, that's IARC, the acting head of the Monographs program. And she will give a summary of the monographs, the IARC findings on the hazard aspects of aspartame. After that, Dr. Branca will provide a summary of the findings of the Joint Expert Committee on Food Additives, also known as JECFA. They're also supported by the technical experts who've done much of the work, and they will be there to answer your questions, including Dr. Federica, you see on camera, Madia, a senior technologist from the IARC Monographs program. Off camera, but certainly will be joining us, is Dr. Moez Sana, who's the unit head, standards and scientific advice on food and nutrition for the World Health Organization. We have huge numbers of you online and only 1 hour, so I'll move on quickly. Over to you, Dr. Branca, to give us an overview.
Thank you very much, Margaret, and good day to all. Thank you for joining us in this press briefing. As Margaret explained, we're here to communicate the results of this recent process of assessment of the safety of the consumption of aspartame, a very popular sweetener that is contained in drinks, food, and is being used for a number of years as a potential replacement for free sugars. The assessment has two components. The first is the hazard identification. It's basically trying to assess whether aspartame can cause potentially harm. The second is the risk assessment, which identifies the actual risk attached to the consumption of the compound at the levels that we can observe in real life. So it's a challenging task, and that's why the WHO has brought together its all its capacity to do that, and bringing together the work of the WHO Agency for Research on Cancer, the International Agency for Research on Cancer, with its long-term expertise in specifically dealing with cancer prevention and management. But then we also have the Joint Expert Committee on Food Additives, which is a joint body that is handled by FAO and WHO, and that advises the Codex Alimentarius. So the assessment of aspartame, which has been done already in the past, it's been requested by the Codex Alimentarius and by specifically the Codex Committee on Additives for review. So we are here today to report this assessment jointly. And since both IARC and JECFA were tasked to do this, we've started a process of very close collaboration and coordination to ensure that the two specialized bodies could have access to the same information, could share methodologies, could share preliminary results. And that's why we're here today to first talk about the aspect of aspartame as an hazard for cancer, but also to then look at how the other potential risks attached, for example, to risk of non-communicable diseases or to other risks could be taken into account. So we will then tell you about the impact that we have analyzed in the context of JECFA. So I'm basically now going to give the floor to my colleague, Mary.
Thank you so much, Dr. Branca. Good morning, good afternoon, and good evening. I am Dr. Mary Schubauer-Berrigan, and I'm the head of the Monographs program at the International Agency for Research on Cancer, which is part of the World Health Organization. We are abbreviated IARC, IARC/WHO. An IARC Monographs working group of 25 international experts met in Lyon to finalize their evaluation of the carcinogenicity of aspartame. These experts, who are all free from conflicts of interest, reviewed all publicly available data according to the strict scientific procedures described in the preamble to the IARC monographs. It is very important to note that this was a hazard identification and not a risk assessment. A hazard identification aims to identify the specific properties of the agent and its potential to cause harm. That is, the potential of an agent to cause cancer. The IARC classification reflects the strength of the scientific evidence as to whether an agent can cause cancer in humans, but it does not reflect the risk of developing cancer at a given exposure level. So the working group classified aspartame as possibly carcinogenic to humans, that is group 2B, based on limited evidence for cancer in humans. This was specifically for hepatocellular carcinoma, which is a type of liver cancer. The limited evidence for hepatocellular carcinoma comes from 3 studies comprising 4 large cohorts conducted in the United States and in 10 European countries. These are the only epidemiological studies that examined liver cancer. All 3 studies examined the consumption of artificially sweetened beverages, which are abbreviated ASBs. The working group concluded that ASB consumption was a good proxy for aspartame exposure given the time periods in which the studies were conducted and the fact that aspartame was the main sweetener used in ASBs during these time periods and countries. All 3 studies were high-quality prospective cohort studies that controlled for many potential confounders. In the European study, a positive association was observed overall between consumption of ASBs and hepatocellular carcinoma incidence. In the 2 U.S. studies, positive associations were observed for liver cancer and ASB consumption in relevant subgroups of the cohorts. Despite consistent positive findings in these 3 studies, the working group concluded that chance, bias, and confounding could not be ruled out with reasonable confidence, and thus they concluded that the evidence was limited. The working group concluded as well that there was limited evidence for cancer in experimental animals, based on a set of studies in mice and rats. There was also limited mechanistic evidence that aspartame exhibits key characteristics of carcinogens. These key characteristics are specifically the induction of oxidative stress and of chronic inflammation, and the alteration of cell proliferation, cell death, or nutrient supply. A summary of the evaluation results, together with the short rationale, will be published online in the Lancet Oncology on the 14th of July at 12:30 a.m. Central European Standard Summer Time. And the complete evaluation will be published in Volume 134 of the IARC monographs in the coming months. The results of the IARC cancer hazard identification should be interpreted in the context of the risk assessment that was undertaken by the JECFA committee, which my colleague at WHO, Dr. Branca, will now describe.
Thank you very much, Dr. Schubauer. And so the JECFA panel was composed of 13 members and 13 experts from 15 countries. All of them have been thoroughly screened for the presence of conflict of interest. The main conclusion of the panel was there's no convincing evidence from experimental or human data that aspartame has adverse effects after ingestion within the limits established by previous committee, which is the acceptable daily intake of 40 milligram per kilogram body weight. So basically the committee reaffirmed the acceptable daily intake level of 0 to 40 milligrams per kilogram body weight. The arguments were, first of all, the analysis of the in vitro and in vivo genotoxicity studies. These studies were giving conflicting results. It was not possible to demonstrate any genotoxic effects, as already indicated by the IARC monograph panel. it was also not possible to have any consistent or convincing evidence from the animal studies. We analyzed 12 animal studies, and only the majority of them were giving negative results. The panel also felt that the studies that were giving positive results were limited in the design and in the quality of the interpretation of the data. The epidemiological studies in humans were identifying some cancer effects and some effects on type 2 diabetes, and as was also identified by the IARC panel, the kind of cancer that were identified were hepatocellular cancer, breast cancer, and lymphoma. However, these are mainly studies that are based on long-term observational. There are some large core studies, but it could not be ruled out that there are effects that confound the results, particularly the estimate of exposure, as was mentioned also by Dr. Schubauer, the issue of not being able to identify specifically aspartame, but using the exposure to all sweeteners as a proxy for aspartame, but also issues around reverse causality, bias, and confounding that despite the good epidemiological techniques that were used in analysis of the data couldn't be completely ruled out. But one of the important elements of the assessment of JECFA was actually the analysis of the absorption of aspartame. Absorption of aspartame leads to immediate breakdown of the molecule into three pieces: phenylalanine, aspartic acid, and methanol. And these three molecules are also found from the ingestion of other food or drink products, and so they are not abnormal metabolites in blood. So aspartame in blood as such could not be detected, and that's a limitation of our capacity to understand these effects. It was also not seen that as a result of ingestion of aspartame, the levels of these three metabolites were particularly increased. As again, the conclusion was reaffirming the acceptable daily intake of aspartame. The full report will be available in 6 months, but a summary report will also be available on the 14th of July on the FAO and WHO websites. Thank you.
Thank you very much, Dr. Branca and Dr. Schubauer. We'll now open the floor to questions. There are a lot of you. I can already see quite a long list, but we're seeing a lot of people with hands up, and it's not clear who you are and what outlet you are. So please, as I said before, put your name and your outlet so we can be sure that you are accredited media. I'll start the first question with James Gallagher from the BBC. James, please unmute yourself and ask your question.
Thank you, everybody, for going through that detail. I just want to zoom right to the end, really, to the point at which somebody is in the supermarket and has to make a decision based on this kind of information. Would you recommend somebody would drink a cola that has sugar in it, or a cola that has aspartame in it, has a chewing gum that has sugar in it, or has aspartame in it, has a yogurt that has aspartame in it or has sugar in it? Because those are the practical decisions that people all around the world will end up making off the back of this advice. And we don't live in an ideal world where everyone has a perfect and healthy diet and only has clean water to drink. So what would you recommend people do, sugar or aspartame?
So over to Dr. Branca for that question.
If the objective of the use of products containing aspartame is to avoid consuming sugar and to avoid the effects of high sugar intake, for example, on body weight, WHO has already released 2 weeks ago another guideline that indicates that, unfortunately, we're not able to demonstrate that long-term consumption of sweeteners, not just aspartame, but also other sweeteners is actually not protective against that excess body weight gain. So as a result of that guideline, the recommendation that WHO made was to moderate both the consumption of free sugars and the consumption of sweeteners. So if consumers are faced with the decision of whether to take cola with sweeteners or one with sugar, I think there should be a third option considered, which is to drink water instead, and to limit the consumption of sweetened products altogether. This is particularly important for young children who will be exposed early enough to a taste adjustment, and they will then basically be in a track of continuing to consume sweetened products. There are alternatives that do not contain either free sugars or sweeteners, and those should be the product that should be preferred by consumers.
Thank you for that answer, Dr. Branca. I'll now call on Milan Sharma from India. We're moving to India. Milan is from the India Today Network. Milan, please unmute yourself and ask your question.
Hi, this is Milan Sharma. I work with the India Today News Network. I just want to understand with these findings, would WHO recommend to these companies to withdraw or recall these kind of products that are already existing in the markets? Because it's not just in a Coca-Cola or say, for example, a chewing gum, but we know that aspartame is used as a sweetener in a lot of products such as toothpaste, etc. So what will be the recommendation from the WHO on this? Thank you.
So I'd like to reaffirm that the conclusion of this assessment are not indicating that consuming products containing sweeteners automatically lead to a health impact. Having an acceptable daily intake, it means it is acceptable to consume a certain amount of aspartame without having appreciable health effects. This amount is pretty large. An acceptable daily intake of 40 milligrams per kilo for body weight, if we consider an average adult of about 70 kilos, translating to 2,800 milligrams per day of aspartame. If we look at, for example, the content of aspartame in common sodas, which is about between 200 and 300 milligrams per day, that means consuming between 9 and 14 cans of these sodas. You can see this is quite a large amount. So definitely WHO is not recommending the producers to withdraw, or authorities to withdraw products from the market. But it would be probably considering the fact that there are some concern that have been identified by some studies, not consistently, with not sufficient clarity. We're certainly advising the consumers to limit the consumption of sweeteners. I also would like to add that the work that's been done, particularly on drinks and food, it's not been done by the WHO guidelines on the chewing gums. Chewing gums, particularly ones containing not aspartame but xylitol, may have actually a positive impact on oral health. So definitely we're not advising companies to withdraw products, nor we are advising consumers to stop consuming altogether. We're just advising for a bit of moderation. The consumption of products containing sweeteners have increased, and the use of sweeteners, including aspartame, have increased to try and respond to consumers' demand to reduce free sugars. But as I said, there is also the option of reducing the sweetness of products altogether, or consuming products that have other forms of sweet taste, such as fruit, that can be used as dessert instead of other products containing other free sugars or sweeteners.
Thank you very much, Dr. Branca, for that answer. The next question will go to Germany, to Christian Ulrich from Deutsche Presse Agency. Christian, please unmute yourself and ask your question.
Thank you, Margaret. And it's a question from Geneva, but for the German press agency. I'm a bit confused. If can you please correct me if I'm wrong? But I understand that nothing has changed about the recommendations from WHO with regards to aspartame. So if that is the case, what has changed? What exactly has is going to be different on Friday from what it is now?
We'll start with Dr. Mary Schubauer.
Yes. So one aspect that has changed is that the IARC Monographs program, which is the world's oldest program of cancer hazard identification, has for the first time conducted an evaluation of the carcinogenicity of aspartame. And so the conclusion of the working group was that it should be classified in group 2B, which is entitled possibly carcinogenic to humans. And this shouldn't really be taken as a direct statement that indicates that there is a known cancer hazard from consuming aspartame. Rather, on considering the fact that there's limited evidence for a single type of cancer in humans, plus limited evidence from the animal studies and the mechanistic studies, in our view, this is really more a call to the research community to try to better clarify and understand the carcinogenic hazard that may or may not be posed by aspartame consumption. And so from a research point of view, we would hope that the community would begin to look at these results and to understand whether there's additional research that might be conducted to help ascertain the answers to those questions. And I think for the more practical aspects of your question, I would return to the comments that my colleague Dr. Branca made about decisions made on a daily basis about what to consume.
Sure, no, and I'd like to add that there are new facts, and the reason why this assessment were done, it was because there were some new facts. There's been some new research that was showing some evidence of potential risk, particularly risk of cancer, but also risk of type 2 diabetes. That is why the member states actually requested both IARC and JECFA to perform this assessment. We don't do this assessment once forever, but this needs to be updated continuously based on the science. I mean, this is the third time that JECFA does this assessment, and each time we have a new piece. I mean, we have had the indication that there is some concern. And, the concerns that these studies have shown are not sufficient at the moment to change basically the codex limit. But it's suggestive that, something needs to be looked at more carefully. As Dr. Schubauer was saying, we need better research. If those studies that had indicated some potential carcinogenicity had been following, for example, certain protocols, probably we would be in a better position to be clearer about that. And, if we could have more epidemiological studies looking at human outcomes, if we had better actually mechanistic study to understand how this compound could actually affect insulin balance or risk of inducing cancer, then we would be in a better situation. I think the new fact is that, we have, in a sense, raised a flag here, indicating that we need to clarify much more the situation. It's not, something which we can dismiss at this moment.
Thank you very much, both doctors, for those answers. Now we'll go to Damien from Quotidien du Médecin, France. Damien, please unmute yourself and ask your question.
Hi, can you hear me?
Very well, go ahead.
Yes. Okay, thank you very much for taking my answer. In fact, I just wanted to know if you could share with us what are the hypotheses regarding the possible mechanical link between the absorption of aspartame and eventually a liver cancer. Actually, so we have this connection with epidemiological studies, but do we have also mechanical studies that can pinpoint a specific mechanism that can explain why we may have some cancer because we absorb aspartame?
Thank you. Good question. And we'll go to Dr. Medea, who looked at those studies to discuss that.
For this question. It's true that aspartame, as was presented before, is almost and completely hydrolyzed in the intestine and in the three components, the 2 amino acid and the methanol, so aspartic acid, phenylalanine, methanol. Still, some of the evidence that we've identified, especially in experimental systems, so in vivo, in vitro, animals and cellular, reported effect on insulin level, so increased insulin level in rodents, and effect that might be linked through different activity through different receptors. The evidence is still limited, and is there where we would like to go through and investigate more. Some of the evidence that our working group collected, still suggestive, were on chronic inflammation and increased angiogenesis. There was also consistent evidence of oxidative stress. Still, some of the studies have limitation, and we will surely go through them in more detail in the future, and hoping that the researcher will go there.
Thank you very much for that answer. I'm looking around the room, nothing more to add, so we will go to Nick Flocco of STAT. Nick, please unmute yourself and ask your question.
Thank you very much. So I just want to drill down further as well for what consumers should know. To put it bluntly, should consumers be concerned about potential cancer risks if they're going and buying aspartame sweetened drinks, casually in the grocery store? Not somebody who's drinking a dozen cans of Diet Coke a day, but someone who's drinking maybe 1 or 2. Should they be concerned about potential cancer risks? Thank you.
So that is why we are using this concept of acceptable daily intake. So there is an element of harm that needs to be confronted with the level of exposure. So the occasional exposure, so basically somebody drinks a soda every once in a while, or has the chewing gum consumption or other products. I mean, aspartame is actually very, very common in many products. Shouldn't have a concern about that. This is what we can say at the moment. So unless we have more solid data to recommend a reduction of the acceptable daily intake, we are sure or we are comfortable that the occasional level of exposure, which is far from the acceptable daily intake, is safe or is not producing appreciable health risk. The problem is for high consumers, and the problem is for situations where consumption are shifting towards high consumer. But I think our results do not indicate that occasional consumption should pose a risk to most consumers.
Thank you very much for that answer. We'll now go to Tanya from Scientific American. Tanya, please unmute yourself and ask your question.
Hi, thanks for taking my question. So I know that these committees were mostly tasked with looking at carcinogenicity, but did you at all look at any evidence of cardiovascular harm or things like heart attack, stroke risk, which I know certain other artificial sweeteners have been associated with? Thank you.
So we did look at all the potential effects on non-communicable diseases. We only found some effects on type 2 diabetes, and this really comes from the observational studies from the cohort studies. So although these are large cohort studies, we didn't have basically a sufficient number of events to be able to identify changes in risk of death for cardiovascular disease or risk for events. But maybe I'll ask my colleague Kim Petersen to comment on that, or Mohassana. Yeah.
Afternoon. Yeah, we analyze all the other effects, all the available data. For the moment, we don't have convincing evidence at all. So for the moment, and I would like to say that the type 2 diabetes was observed only in one cohort study. And one of the principles of epidemiological study and how to move from association to causation, we need a certain consistency. So we cannot rely only on one single study done in one country. And that's why we say it's non-convincing, despite the fact that this cohort study is one of the best study where aspartame was correctly assessed by the consumer through a different questionnaire, looking at the table of composition. It is a very good, very well-designed, well-conducted study. However, it is only one single observation, and we cannot provide public health conclusion with only one study.
And if I can also add, I mean, the other effect was cerebrovascular disease. But again, these are associations which are difficult to interpret. We have not clearly identified a potential mechanism of action. Potentially, the insulin sensitivity could be, of course, a pathway, but we need to have more demonstration about that. And, you know, as Dr. Sana was saying, these are observational studies. And, you know, the big issue has been the reverse causality. So basically, you know, did we include, patients already then? Because of being patients, they were consuming the sweeteners to address their health concern. And, you know, there are epidemiological techniques that allow us to actually, account for that. And so that was done. So there's still some effect there. So we cannot rule out completely the health effect. But at the same time, you know, it's just one study. There are methodological limitations. So that's why we're very cautious in interpreting those effects. But again, we cannot rule them out. They have been described by some studies, by one study actually.
Yes.
Thank you very much. The next question goes to Miriam Nadaf of Nature. Miriam, please unmute yourself and ask your question.
Thank you. I'd really like to know what are the current gaps in research that needs to be addressed by academics to improve future hazard identification or risk assessment of aspartame. And this could be particular study designs or particular areas, effects to be investigated, or studies in places other than the US and Europe. I noticed most of the studies you mentioned were centered in the US and Europe. Thank you.
Yes, this is Mary, and I'll take that question, and I'm sure my colleagues would also like to echo or to reflect on their own thoughts. It is true that most of the observational epidemiology studies that were done for cancer were conducted either in Europe, although they have broad diversity across European countries with different lifestyles and income levels, and in the US. It's definitely true that a more diverse set of studies across the globe would be needed to understand fully whether there is a carcinogenic hazard from aspartame consumption. One of the key limitations of the existing studies is that most of them measured artificially sweetened beverage consumption only at a single time point, with the exception of a few studies. All three of the studies that I mentioned for liver cancer only collected data at a single time point. And so from an epidemiological perspective, the working group concluded that the most likely impact of that limitation is that it would tend to lead to exposure misclassification that would be randomly distributed across the entire cohort. And this tends to cause bias towards a null value. So they didn't feel that this limitation was really impeding their ability to understand what the findings were. However, it meant that the studies currently don't have very good sensitivity to detect effects. And so one of the key research gaps is to have better quality exposure assessment, particularly for individual artificial sweeteners. And for example, the Nutrinet Santé cohort in France, which Dr. Sana has already alluded to, did in fact undertake that in a very detailed manner. And it would be very helpful to have more and similar studies. At the same time, it would be helpful to have more mechanistic studies in consumers of these products and these sweeteners to understand more the mechanistic pathways. And I think that some of that research, speaking to my colleagues at IARC, we are a research organization, some of those studies are already in the initial phases or are in conception stage right now. But I think the global community could undertake more and better research to understand these sort of non-traditional pathways to carcinogenesis, other than genotoxicity, which is sort of the classic mechanism of carcinogenesis. But I'll turn to my colleagues in JECFA for their thoughts.
I will add, I agree with what you said about the epidemic study. Yeah, we need better estimation of the consumption of aspartame, and we need more time because we are on chronic disease. We need more time, and we see when you look at the in-depth analysis of the current data, we see some association that occur when we have longer period of time. So, for example, one of the study you have only 10 years of follow-up. We encourage that those cohort study continue to collect the data, continue to better assess the exposure to aspartame. This is in one hand, the continued epidemiological study and cohort study. On the other hand, we need some perhaps more innovative approach for the mechanism of action. I just to explain that in the majority of the in the epidemiology study, when we are comparing high consumer to low consumer, comparing the ADI, they are at very low exposure. So we are looking if there is association between aspartame and cancer or other adverse effect. They are occurring at very low doses. That means we have different mechanisms that one we are use it to analyze the toxicological principle of when you see effect at high doses. So there is still uncertainty, unknown mechanism, or known or unknown. So we need to explore more mechanism of action.
Thank you very much. And the next question goes to Danny Bloom of the New York Times. Danny, please unmute yourself and ask your question.
Hi, I'm wondering for people who are high consumers of aspartame and they have been throughout their life, how worried should they be presently about the risk for cancer? What should they do?
So, as I said, high consumers are maybe close to that acceptable daily intake. Get aspartame not just from sodas, but from other products. And, you were talking about the United States. I think aspartame is a very common sweetener, so it's contained in many products. Well, there's only a very obvious recommendation to give, bring down the consumption. It's not a solution. It doesn't provide benefit if you want to curb your energy intake. In the longer term, it doesn't help. So basically, the benefit is not there. We know that. We've been demonstrating also with a series of systematic reviews. And, well, the risk may be there if you're approaching the ADI, if you're approaching the limit. So why take that risk? So our recommendation to the high consumers is to reconsider their pattern of consumption.
Thank you very much for that answer. Now we'll go to the Financial Times, to Donato Mancini. Donato, unmute yourself and ask your question.
Hi, good afternoon. Thanks for taking my question. I hope you can hear me. So just to get it clear, the part about aspartame being a possible carcinogen because of a potential link to hepatic cancer is new, but the evidence is limited, correct? The acceptable daily intake stays as it was. There is no change there. Yes, I see you nodding, so that's reassuring. I understand that the actual question is this. You say we need better research, but what should companies do? I mean, should they seek out new types of sweeteners, new sweeteners in the same category, or should they cut them out altogether? This is a broader question that I hope you can give me something interesting on. Thanks.
So definitely companies could reconsider their products. This is the general advice we give to food manufacturers, to use ingredients that do not require the addition of too much sugar or the addition of too much salt. In this case, I think we're also indicating that sweeteners is probably not the way forward. We're advising companies not to consider alternative sweeteners. Alternative sweeteners, as I said, from the point of view of the benefits, we don't have anyone that is even including the latest ones that are demonstrated to be producing positive health benefits. And we don't know. We know about most sweeteners about the risk. So we have if they are used as additive, it's because they are allowed as additives, and so there is an acceptable daily intake. But it's not about really looking at new alternatives for the moment. It's about changing the formulation of products and changing the choice of ingredients so that you can have still tasty products without the need to use sweeteners.
Thank you, Dr. Branca. Now we'll go to Agence France Presse, to Agnès Pedrero. Agnès, please unmute yourself and ask your question.
Yes, hello. Hi, thank you everybody for taking my question. You say that the acceptable daily intake hasn't changed. It's still 40 milligrams per kilo body weight. And given that a lot of these products are taken by children, by adolescents, I would like to know if you could give us examples of how much that safe consumption represents.
I mean, just make your calculation. So let's say a child. Do we want to consider 20 kilograms, 30 kilograms? Let's say a child of 20 kilograms. That means 800 milligrams. That means 2 or 3 cans per day of soda. So you may have children who have high consumption of sweetened sodas. That's not a good practice. You may have families that instead of having water on the table have a big can of sparkling drinks with sweeteners. That's not a good practice. So definitely you're right in saying that children may be at a high risk, also because starting consumption early in life not only puts you in a track of being accustomed to that taste and levels, but also because we have really a long-term exposure, and I'm not sure whether our studies have been able to tell us about a lifelong exposure. That's another research question. Maybe you want to comment on that.
Yes, absolutely. So in the case of aspartame, it was authorized in the early 1980s. And so myself, at my age, I remember very clearly when these products first came on the market. And so, I'm not yet at the age when cancer is going to really be very high in the population. So we've only really had population level exposures to these products for a maximum of say 40 years. And so yes, this does have an impact on what information we currently have from the existing published studies, as Dr. Sana was saying. Would you like to complement that as well?
Yeah, thank you. Yeah, I would like to say that in JECFA, in addition to toxicological profile and looking at the adverse effect, we did a lot of work on estimation of the current exposure. And I would like to say that for the high consumer today, and we look at different countries, different situations, the worst scenario, they are not exceeding the current ADI. So it is less than 30 milligram per kilogram of body weight, less than the limit 40. And this is for the high consumer, and saying that our estimation are overestimating because you don't have all the data, but using a method that overestimates, we don't see consumer higher than the ADI, and the majority of population are less than half or 10 times less than the ADI.
Thank you very much for those comprehensive answers. The next person to get a question is Kerry Cullinan from Health Policy Watch. Kerry, could you please unmute yourself and ask your question?
Thank you, Margaret. My question is related to a study that was published last week, which said that found links between aspartame and Parkinson's, possibly. Only in animal studies, but there was an impact on memory loss and also an impact on brain dopamine levels. So I just wondered whether the researchers had any comment on that. Thank you.
Branca.
Yeah, thank you very much for pointing out to that study, but I'm afraid that this study has not been considered in our evaluation. Our evaluation actually been concluded before its publication, so we're not able to comment on that. But thank you for pointing us to that study. It's a very important element. Thank you.
Thank you very much. I'll now go to Betsy Mackay from the Wall Street Journal. Betsy, please unmute yourself and ask your question.
Okay, thank you. Can you hear me?
Very well. Go ahead.
Okay, thank you so much, and thank you all for the helpful information so far. I wanted to go back to a couple of things just to get a little more information, a couple of points you made earlier. One is, I wondered if you could explain a little more fully why both IARC and JECFA did assessments, you know, at the same time. I mean, as far as I understand, it's a little bit unusual for both arms to do assessments. And the second or related question is, so then how do you then avoid or prevent consumer confusion over your assessments, which are to the average person sound very different? One, that there's a possible hazard of carcinogenicity, and the other that that aspartame is safe at currently recommended levels. So I just wondered if you could say a little bit more about both of those points.
Yes, thank you. Those are great questions. And I'll start from the IARC perspective and then turn it over to Dr. Branca from the JECFA perspective. So both organizations, IARC and JECFA, had been given advice by, in our case, an advisory group of experts in 2019. And in JECFA's case, it was, I believe, from the Codex group, but they will explain that further. But in our case, this recommendation was made 4 years ago to evaluate the potential carcinogenic hazard of aspartame with high priority. And this was on the basis of new evidence that was emerging both from animal cancer bioassays and from studies of human cancer, given, as we said before, the long latency that has occurred. So, as I said previously, IARC is really often called the WHO's encyclopedia of carcinogens. And in our long 50-year history, we've evaluated more than 70 food additives, including other artificial sweeteners. So it's not at all unusual for us to be recommended to evaluate these agents. However, we are also mindful of the fact that our partners in WHO and JECFA will be interested in risk assessment. And so starting almost 2 years ago, we began discussing a joint effort to carry out first a hazard identification for cancer through the IARC monographs, followed by a risk assessment from the JECFA committee. And so those two efforts have been carefully coordinated. As Dr. Branca mentioned at the beginning of the press conference, there was an extensive effort made to share information and to ensure that the same set of studies was reviewed by both groups. Now, that said, the evaluation criteria of the two programs are different. But what is important to reflect on is the fact that both evaluations identified that there was some positive evidence of potentially harmful effects, in our case cancer, in their case cancer and other endpoints. However, the evidence was not of sufficiently high quality or convincing enough to take that extra step of altering the ADI for aspartame. So these are two complementary processes, and in a risk assessment paradigm, which is really, I realize, a very jargony expression, but the work of hazard identification does typically precede the work of risk assessment. And this is why IARC began the process in June with our cancer hazard identification, and JECFA experts were made aware and observed some of these proceedings themselves so that they could then take that information and conduct their own risk assessment. Before I turn it over to Dr. Branca, one additional facet that's not perhaps as well appreciated is that cancer hazard identification considers all routes and types of exposure. And we did identify in this case that there are workers who are exposed to aspartame during its production and use. And while we had not a lot of evidence, there is some evidence that there is inhalation exposure. And so some of the information, particularly from the mechanistic studies of oxidative stress, could be more relevant to an inhalation exposure than to a dietary intake. And so for the cancer hazard identification, looking at all of those types of exposure is quite important.
And thank you for the question. Do you know how many people die every year as a result of cancer? 10 million. So of course, the WHO has definitely an important responsibility to be completely, to be thorough in looking at all potential harms or harmful compounds or processes that may lead to cancer initiation or progression. So there's a societal concern that our organization needs to respond to. So as Dr. Schubauer said, both IARC and JECFA were tasked to do this, and we respond to our member states. So we have to do this. And what we have done is actually try to combine these two assessments in a way that we could make the best out of the respective mandates, expertise. We have adjusted the procedure to avoid, for example, that these two groups were not considering the same pool of data, or the experts were not informed about each other's work. So we actually made it work this way, so that the process was complementary, not duplicative, certainly. That we were looking at from a different point of view. Dr. Schubauer mentioned other routes of ingestion, looking at cancer. In the case of JECFA, we're looking at dietary intake, but we're also looking at not just cancer effect, but other cancer effects. So by bringing together our two organizations, and we purposely designed the time to be consecutive so that we could avoid giving conflicting messages, and that's why we've been careful in trying to avoid that the incomplete information is disseminated to the public. We want to be very transparent and very clear about what these results mean, and that's why we're asking you to wait until the 14th to really look at the details of the two reports, so that there's no misunderstanding and that a very clear, consistent message can be given to the general population.
Thank you very much, and I couldn't agree more. There are a couple of clarifications. Damien is asking whether or not IARC has assessed the hazard before. I know that they have not, but Mary's nodding, that's correct. And we've got a follow-up from Miriam asking, will we continue to follow up on this particular subject? Perhaps we need to explain the mechanism of the bodies. We do the assessment. If there's more data or there's a request to do it again, we have another meeting. Is that correct?
I can explain for IARC that process. As I mentioned, in 2019, we had an advisory group of international experts, again, free of conflicts of interest, who gathered in Lyon to look at a list of more than 170 what we call agents, which could include chemicals, physical agents, viruses, and other biological potential carcinogens. And they carefully looked at the existing evidence to advise IARC, and of course in that capacity WHO, on which potentially carcinogenic agents should be reviewed by the monographs. Some of them were listed for the very first time for evaluation, never having been done before, like aspartame. Some are mentioned many times because the evidence has evolved and changed, and so the research community would like IARC to look at these again. We're convening another meeting, just like the previous one, in March of 2024. And we do open this call to the entire public, the scientific community and the general public, to nominate agents for evaluation by the monographs in the next 5-year period. We operate on 5-year cycles. So the scientific community and public are encouraged to nominate agents for the first time or repeat evaluations, and our advisory group will sift through all of these to determine whether they merit consideration at a future meeting. Thanks.
Yeah, I can add something. So For JECFA, we answer to the question coming from the Codex Alimentarius, mainly the Codex Committee for Food Additives. However, JECFA has the capacity to self-task. If we have new evidence, important evidence that are linked to public health, we have one annual meeting of JECFA, and it can be discussed as a part of the JECFA meeting. So this we are watching, monitoring the new evidence, and if there is important new evidence, we will open the file.
Now we'll go to Reuters, to Jennifer Rigby. Jennifer, please unmute yourself and ask your question.
Hello, thanks for doing this. I just wanted to ask why now, particularly for IARC, but I know you said that it was nominated by the experts on the working group, but there was also a nomination, as far as what I've read, in 2014 for the previous cycle. So I just wondered why not then, and why now, and when the studies that you mentioned, particularly the ones around liver cancer, were published. Yes. That would be great. Thank you.
Yeah, of course, and great question. Yes, you're correct. The 2014 advisory group also recommended aspartame, and this was on the basis of the then fairly new set of studies that was published by the Ramazzini Institute, as well as a few, not very many, human cancer epidemiological studies, particularly some findings of leukemias in the Nurses' Health Study. So one important thing to note is that IARC is resource constrained, and we cannot evaluate all of the agents that appear on our priority list each 5 years. So agents that we have not been able to get to for whatever reason are then put forward for reevaluation by the next advisory group. And so aspartame didn't make it out of the queue in the 2014 group, which is very common, but it was reevaluated, and there was yet new evidence, including some new studies. The first study of the hepatocellular carcinoma that I mentioned was published in 2016. And then since then, and as is often the case, when agents are put on our high priority list, the research community swings into action, and they finish the publication of many of their ongoing long studies. Or they may decide to look at artificial sweeteners in the context of their studies. So the other two studies on liver cancer were published after our priorities report. So our advisory group was not even aware that they existed. And so these were the two large studies that were from the United States. So the 2016 paper was the European cohort, and then the two subsequent studies were published, I believe, in 2020 and 2022. The Nutrinet Santé cohort study was published in 2022, but by then, as I mentioned, we had already been in discussion with JECFA about conducting this sequenced hazard identification and risk assessment. Thank you.
Thank you very much. We're well over the hour, but we did start a little late. So I'll just ask one small follow-up, because while I've got you all here, this is Nick from STAT, who's asking which member states requested the reviews. If you don't know right now, we can always send you an answer, Nick, via media inquiries. We can check. But if you do know.
Well, in our case, it's not member states that we're responding to, but it's the advisory group on priorities. And so we carefully review all of the priority agents, and we do look to see whether there are opportunities to collaborate, especially with our partners in WHO. So it was not, in this case, to my knowledge, a request of member states, but rather the high priority given from the advisory group in 2019.
Yeah, for JECFA, this is actually something which is done by the whole Codex Committee. So, we cannot identify a specific member state to request it.
Yeah, it's always the decision is made by consensus in the Codex Alimentarius. It's going through the different steps, discussion paper, discussion at the Codex Committee, at the Commission, and so on. And usually in the report, we don't put the name of the member state who requests. So the report, a member propose, and the other members support, and by consensus, we decide to review or not to review.
Thank you. I think that's very clear. And I must thank you all for such clear and full answers. We will now have to close because there are some pressing commitments coming on right now. But I ask the expert panel if they've got any closing remarks, anything they feel needs to be emphasized that's been missed out.
I can't think of anything. I thank you all for the wonderful questions, and thanks to you, Margaret, for the wonderful moderation.
Yeah, thank you. Thank you for your question, and we will try to answer if there is more request about more technical question, so we can connect with you. Thank you.
And for me, just to invite everybody to really look at the full reports. I think the details are important. We appreciate the scientists who have been contributing to this work, but also we invite the scientists to take on our call for additional research, and to the funders of research to actually allow this to happen, because unless we have solid science, it's very difficult for the bodies that provide scientific advice to make recommendations. So it's not an ideal situation to be able to give you results that still open questions, but that's the reality. And we also would like to thank you all for taking up the implications for consumers. Clearly, it's really important that we all recommend a healthy diet, and we're actually tomorrow are going to again talk about that in another event where we are launching our guidelines on carbohydrate fats under the umbrella of an overall healthy diet. So more to come on this. Thank you.
Thank you all, and I thank you all members of the media. Those were really good, great questions. And I'm thanking you in advance for respecting the embargo so that we can all be very, very happy about this engagement. The embargo, as I said before, lifts 0030 Friday morning, Friday, January 14. And that's the embargo for absolutely every word said in this press conference and all the materials that are provided as well. So thank you all, and see you in our next press conference.